Welcome to the Hospital Medicine Unplugged podcast. Today we're doing a deep dive into, well, one of the most critical situations we face in hospital medicine, acute variceal bleeding. This is really a scenario where every second counts, and getting multiple complex therapies going at the same time is absolutely key for survival.
It really is. It's a true medical emergency. We're dealing with bleeding that stems from portal hypertension, usually from cirrhosis, right? And it's the cause for what? About 70% of upper GI bleeds in these specific, very high-risk patients. You just can't approach this like a standard ulcer bleed. It's a different beast entirely.
And the stakes, they become immediately clear when you look at the mortality data. We sometimes think of GI bleeds as having relatively low mortality these days, but with varices, that picture changes dramatically.
That's the really sobering part we have to face. Even with all our current treatments, the in-hospital mortality for acute variceal bleeding is somewhere between 4% and 13%. But then you look just a bit further out, say 6 weeks. That number can jump dramatically, potentially hitting 43%, especially in patients who have really advanced liver disease, high Child-Pugh scores. That statistic alone is why we need such aggressive, structured approaches. So basically, we're talking about acute hemorrhage from these dilated submucosal veins, the varices, usually esophagus or stomach, needs fast diagnosis, fast intervention.
Okay, let's break down the root cause a bit, the pathophysiology. Because understanding why these vessels rupture really guides our initial strategy, especially with things like vasoactive drugs. It all starts with portal hypertension, obviously. But what exactly makes that pressure build up so much?
Portal hypertension is the direct cause, yes. It comes from increased resistance to blood flow inside the liver, and also, interestingly, increased flow into the portal system. The resistance part is structural, the fibrosis, the scarring, the nodules from cirrhosis, but it's also dynamic.
Dynamic resistance. What do you mean by that?
Well, it means the resistance isn't just about the fixed scar tissue. The hepatic vascular tone itself is actively increased. This happens because of endothelial dysfunction and less nitric oxide available within the liver sinusoids. So the vessels inside the liver are actually clamping down, adding significant pressure.
So pressure builds up, and the body tries to find escape routes, basically, creates shortcuts.
Exactly. When that pressure difference, the hepatic venous pressure gradient, or HVPG, gets above 10 to 12 millimilli Hg, the body compensates by forming these portosystemic collaterals. And those are the varices. They're vessels that were never meant to handle that kind of pressure or flow. They're thin-walled, dilated, missing that tough muscular layer.
The 10 to 12 millimilli Hg threshold seems really important. That's when they form. But when do they actually burst?
Rupture is almost inevitable once the pressure just overwhelms the vessel wall's capacity. It's a mix of high transmural pressure, that pressure pushing outwards, and the tension it creates. It just stretches beyond the wall's limit. But what really makes it worse in advanced cirrhosis is that it's rarely just a mechanical rupture.
Ah, you mean the other systemic factors that turn a bad situation into a catastrophe?
Precisely. You've got the systemic inflammation that's just part of decompensated cirrhosis. You've got bacterial translocation from the gut, which fuels that inflammation. And then there's the complex coagulopathy. While the INR and PTT, APTT might look high, the whole system is out of whack. Patients can be both pro and anticoagulant, but the key thing is their ability to form a stable clot is severely impaired. This whole mix makes the bleed worse, harder to stop, and much more likely to spiral into organ failure and death.
Okay, given that really dangerous scenario, let's move straight into that critical first phase. Initial assessment and stabilization. Patient hits the ER door, where do they need to go immediately?
ICU. Absolutely no question. These patients belong in the intensive care unit. The risk of decompensation is just too high: hypovolemic shock, acute kidney injury from poor perfusion, acute hepatic encephalopathy. They need continuous, intensive monitoring. This isn't something you manage on the floor.
And before we even think about endoscopy, there's a crucial step, especially if the patient is unstable or actively vomiting blood.
Airway protection.
Yes, this is often a very high-stress procedure in this setting, but it's absolutely essential. If the patient has ongoing hematemesis, just massive vomiting of blood, or if they have altered mental status from hepatic encephalopathy, you need to strongly consider intubation before the endoscopy. The risk of aspiration pneumonia in someone with cirrhosis is incredibly high and often tips the scales, worsening outcomes significantly. Secure the airway first.
Let's talk about the resuscitation strategy. This is maybe one of the most counterintuitive parts for many of us. We're usually trained to pour in fluids for massive GI bleeds, but here it's cautious volume control. Why restrict fluids and blood? This is probably the single most critical point to get right in variceal bleeding. The goal is a restrictive transfusion strategy. We aim for a target hemoglobin of around 7 GDL. The reason is simple. Aggressively pushing volume raises central venous pressure, and that directly raises portal pressure. Since high portal pressure is driving the bleeding, giving too much packed red cells or even too much saline can actually increase the pressure gradient across the variceal wall. It can cause rebleeding or prevent a clot from forming properly.
So keeping the hemoglobin target lower is actually a therapeutic move to keep portal pressure down.
Exactly. It's a calculated trade-off. We're potentially accepting slightly lower systemic oxygen delivery in exchange for lower portal pressure to stop the bleeding. Now, the exception might be a patient with severe coronary artery disease or an active heart attack, where maybe you'd aim a bit higher, perhaps 8 or 9 GDL, to protect the heart. But for the typical cirrhotic patient without those severe comorbidities, 7 GDL is the standard.
Okay, shifting to the initial labs. What core markers do we need right away to guide resuscitation and assess risk?
Immediately, you need the full picture. A CBC, obviously, for hemoglobin and platelets. A BMP to check electrolytes, and, very importantly, kidney function. Watch that creatinine closely. Acute kidney injury is a major prognostic sign. Liver function tests, including bilirubin and albumin, are key. And a coagulation profile INR, PTA, PTT. And of course, get a type and cross-match done urgently.
Let's focus on managing that coagulopathy for a second. It's really tempting to see a high INR or low platelets and want to fix it with FFP or platelets, but we're told not to do that routinely.
Right, and the evidence backs that up. Routine transfusion of FFP or platelets just based on the numbers like an INR of 1.8 or platelets of 50,000 is actually discouraged. Remember, giving FFP is basically giving volume, which risks bumping up that portal pressure we just discussed. These products should really only be used if the patient is actively, uncontrollably bleeding despite everything else, or maybe right before an invasive procedure like TPS, or perhaps if there's clear clinical evidence of something like fibrinolysis. Just chasing the lab values often does more harm than good by potentially worsening the bleeding.
That really reframes it. We're treating the patient and the pressure problem, not the lab result itself. One last point before endoscopy. What about routine NG tube placement?
Generally, routine NG tube placement is discouraged. Yes, it can confirm bleeding, but the risk of triggering more hematemesis, or worse, increasing the already high aspiration risk, usually outweighs any potential benefit. If you really need to assess gastric contents, it's better done under controlled conditions, or ideally, just wait for the endoscopy itself.
Okay, that really sets the stage for stabilization. Once we've got the patient hemodynamically under better control, the second track starts immediately.
Yeah.
Pharmacologic and endoscopic therapies. We can't wait for the scope to start the drugs, right?
Absolutely not. The pharmacologic therapy is crucial because it works to lower portal pressure right away. It has to be started as soon as you even suspect variceal bleeding. Don't wait for confirmation.
The go-to drug in the US is usually octreotide. How fast does it work, and what exactly is it doing?
Octreotide is a somatostatin analog. It's the standard here. You give an initial 50 microgram IV bolus, then start a continuous infusion at 50 micrograms per hour. Its main effect is causing splanchnic vasoconstriction.
Wait, constricting vessels, wouldn't that raise blood pressure and maybe increase flow?
But that's the key difference. Octreotide preferentially constricts the blood vessels supplying the splanchnic circulation. This dramatically reduces the amount of blood flowing into the portal system. Less inflow means lower portal pressure. And it does this without causing major systemic vasoconstriction. So you typically see big spikes in blood pressure or problems with organ perfusion elsewhere. It's targeted.
So basically buys time for the endoscopist by lowering the pressure. How long do we keep it running if the scope confirms varices were the source?
If endoscopy confirms variceal bleeding, you should continue the octreotide infusion for a set period, usually somewhere between 2 to 5 days. This sustained pressure reduction helps stabilize the clot that was hopefully achieved during the endoscopy.
And running parallel to the vasoactive agents is the mandatory use of prophylactic antibiotics. This is for every cirrhotic patient with an upper GI bleed, correct? No exceptions.
Correct. This is one of the interventions with the clearest mortality benefit. Patients with cirrhosis are significantly immunocompromised and very prone to infections, especially spontaneous bacterial peritonitis, or SBP. An infection dramatically increases the risk of rebleeding, makes it harder to stop the initial bleed, and increases mortality. So yes, prophylactic antibiotics are absolutely mandatory. Start them immediately.
And which agent do we prefer now? Resistance patterns have shifted things.
Intravenous ceftriaxone, 1 gram IV every 24 hours is generally the preferred first-line agent in most places now. We've largely moved away from oral fluoroquinolones because resistance rates, especially in hospital settings, have become quite concerning. You continue the antibiotics for up to 5 to 7 days, or at least until the bleeding is well controlled and the immediate risk of bacterial translocation seems lower.
Okay, so stabilization is ongoing, drugs are running. Now we need the procedure itself. An urgent upper endoscopy. How urgent is urgent? What's the window?
The standard is within 12 hours of presentation, but, and this is critical, urgency comes after safety. You only proceed with endoscopy after the patient is reasonably hemodynamically stable and, if needed, the airway is secure. Rushing into a scope on an unstable patient is dangerous. But waiting too long after stabilization risks more blood loss and further decompensation. So that 12-hour window is generally the target.
Is there anything we can give beforehand to improve the view for the endoscopist, especially if there's been a lot of blood?
Yes, sometimes we use erythromycin before the procedure. We're not using it for its antibiotic properties here, but for its prokinetic effect. It stimulates gastric motility, helping to clear out residual blood clots and stomach contents, hopefully giving the endoscopist a much clearer view to find and treat the bleeding varices.
All right, let's talk about the main endoscopic treatments, starting with the gold standard for esophageal varices.
For esophageal varices, endoscopic variceal ligation, or EVL, is definitely the gold standard. This involves placing small elastic bands around the base of the varix. It essentially strangulates the vessel. This causes thrombosis, necrosis, and eventually the varix scars down and disappears. It's highly effective. Initial hemostasis rates are very high, like 90% to 97%.
What about endoscopic sclerotherapy, EST? Is that still used much?
EST is really considered second line now. It involves injecting a sclerosing agent, basically an irritant, into or beside the varix to cause clotting and scarring. It's mostly reserved for times when EVL is technically just not feasible, maybe due to anatomy or if EVL has already failed. The main reason it's second line is its higher rate of complications, things like deep ulcers, chest pain, and a risk of developing esophageal strictures later on. EVL is generally safer and just as effective.
Okay, now we get into the really tough situations, refractory bleeding and advanced interventions. How do we define refractory bleeding? What does it tell us about the patient's immediate outlook?
Refractory bleeding is when the hemorrhage continues, or starts again soon after. Despite doing everything right initially, optimal vasoactive drugs, the mandatory antibiotics, and a technically successful first endoscopic attempt, usually EVL. If a patient is still bleeding significantly or rebleeds within those first crucial 5 days, they've entered a very high mortality situation. It means we need to escalate therapy immediately.
If the endoscopist can't get control or fails, we need something fast to bridge the gap while arranging the next step. What are those temporary life-saving measures?
These are mechanical bridge therapies, kind of a last resort before definitive treatment. The classic one is balloon tamponade, using something like a Sengstaken Blakemore tube. It has balloons you inflate in the esophagus and stomach to physically compress the bleeding site. Sometimes self-expanding metal stents are placed in the esophagus too.
But those carry significant risks themselves, don't they? Pressure, necrosis, aspiration.
Oh, absolutely. They are strictly temporary. We're talking hours, not days. They need very careful placement, constant monitoring, and usually require the patient to be intubated. Their only role is to stop the bleeding long enough to get the patient to the definitive treatment, which in this refractory setting is almost always going to be TIPS.
Right, the definitive salvage therapy. TIPS, the transjugular intrahepatic portosystemic shunt. That's placing a stent between the portal vein and a hepatic vein to bypass the liver and lower pressure. When should we be thinking about early TIPS?
Early TIPS, ideally within 24 to 72 hours of the initial bleed, is the key salvage therapy. It's indicated for patients who fail that initial endoscopic control or, and this is important, for specific high-risk patients identified right from the start. We're shifting towards being preemptive rather than just waiting for failure.
Let's focus on that preemptive idea. Who are the patients that meet the criteria for considering this early, aggressive TIPS approach?
We specifically target the patients who are at the highest risk of rebleeding and death, where studies have shown a clear survival advantage with early TIPS. This primarily includes patients with advanced liver disease, child Pugh Class C, usually a score of 10 to 13, or patients in child Pugh Class B with a score over 7 who present with active bleeding during their initial endoscopy. For these specific groups, getting that portal pressure down quickly with TIPS is crucial.
That's a major decision point.
Yeah.
If we go for TIPS that early, what are the main downsides we're accepting? Because shunting blood past the liver has consequences.
That's the fundamental trade-off, exactly. TIPS is excellent for lowering portal pressure and stopping rebleeding. But the major downside is an increased risk, often significantly increased, of hepatic encephalopathy after the procedure. You're essentially allowing toxins from the gut, like ammonia, to bypass the liver's filtering function and go straight into the systemic circulation. This means patients need close monitoring afterwards and often need more aggressive treatment with lactulose or rifaximin. So while we improve survival in these very sick patients, we have to manage and counsel them about the potential for worsened neurological function.
It really changes the game from just stopping the bleed initially to doing aggressive risk assessment right in the ED or ICU.
Absolutely. If you have a patient admitted with active hematemesis and their Child-Pugh score is, say, 11, you should be having a conversation with interventional radiology and hepatology almost immediately about planning for that potential 24 to 72-hour TPS.
Let's shift gears slightly to managing some special situations, different locations for varices and non-cirrhotic causes. Gastric varices, GVs, are managed quite differently from esophageal ones.
Yes, they often require a totally different approach. This is because the anatomy of the vessels is different, and they often have very high-flow feeding vessels, frequently involving the splenic vein.
We usually use the Sarin classification for gastric varices. Let's start with the GOV1 type.
Right. GOV1 varices run along the lesser curve of the stomach and are essentially continuous with the esophageal varices just above them. Because they're structurally similar and in continuity, EVL banding is still the preferred treatment for GOV1s. You treat them almost like complicated esophageal varices.
Well, when we move over to the fundus, that large upper part of the stomach for GOV2 or the isolated IGV1 varices, banding usually doesn't work well. Why is that?
Fundal varices tend to be much larger, more tortuous, and have significantly higher blood flow going into them. Trying to put bands on them often fails technically. The bands slip off, or they just rebleed very quickly. So for these fundal varices, the first-line treatment is usually endoscopic cyanoacrylate injection, or ECI.
ECI, that's essentially injecting medical-grade superglue, right?
Mm-hmm.
Why is that necessary? What makes it so tricky?
Pretty much, yes. ECI involves injecting a mixture of cyanoacrylate adhesive and an oil-based contrast agent directly into the varix itself. The goal is to create a solid cast or plug inside the vessel, blocking the flow very rapidly. But the technique is challenging. It requires real expertise. You have to inject precisely to avoid gluing the needle inside the varix, and critically, you have to manage the injection volume and speed carefully. You don't want the glue migrating downstream and embolizing before it hardens.
Embolizing meaning the glue travels to the lungs or brain.
Exactly. It can cause serious complications like pulmonary embolism or even stroke. That's why if a center doesn't have specific, regular experience with cyanoacrylate injection for gastric varices, the patient really needs to be referred urgently to a tertiary center that does. This isn't a procedure for occasional use. Often it's done in coordination with interventional radiology, who might add coil embolization afterwards for extra security.
Okay, moving beyond the stomach, what about ectopic varices, varices elsewhere?
Ectopic varices pop up outside the usual esophagogastric area, think duodenum, colon, rectum, even around stomas. They're less common, but when they bleed, it can be incredibly severe, often torrential. Management is very specialized and depends heavily on the location. Endoscopy might be tried first, but often isn't successful. The mainstays for definitive treatment are usually either TPS, since it decompresses the whole portal system, or highly targeted embolization procedures done by IR. This requires detailed imaging like CT or MRI scans to map out the complex blood supply feeding these ectopic sites.
And what about that group of patients who bleed from varices but don't actually have cirrhosis, non-cirrhotic portal hypertension, or NCPH?
Right. NCPH includes things like portal vein thrombosis, infections like schistosomiasis, or sometimes isolated splenic vein thrombosis, maybe from pancreatitis. When these patients present with an acute bleed, the initial management stabilization, vasoactive drugs like octreotide, antibiotics, urgent endoscopy, is pretty much the same as for a cirrhotic patient.
But the long-term strategy and potential cure can be very different based on the underlying cause.
That's the crucial difference. If the NCPH is from extensive portal vein thrombosis, they might still end up needing TPS eventually. But if it's caused by something isolated, like splenic vein thrombosis blocking outflow just from the spleen, then treatment can actually be curative. In that specific case, removing the spleen surgically, splenectomy, or blocking the splenic artery with embolization can completely resolve the localized portal hypertension and stop the bleeding risk permanently. This really highlights why a thorough workup involving hepatology, IR, and good cross-sectional imaging is essential in these non-cirrhotic cases to pinpoint the exact cause and guide treatment.
It really underscores how vital that imaging is, not just for diagnosis, but for planning interventions like ECI, TPS, or embolization.
Absolutely. You have to understand the anatomy and the flow patterns to pick the right approach.
Okay, let's move towards wrapping up with long-term management and prognosis. We stopped the acute bleed, but the work isn't done. What are the big early complications we worry about in the days and weeks after?
The early period is dominated by the consequences of the initial bleed and the body's response. Things like persistent shock if resuscitation wasn't optimal, infection, which is why those prophylactic antibiotics are so key, acute kidney injury, which is a really bad sign prognostically, and of course, worsening hepatic encephalopathy. And it's important to remember, most of the mortality associated with a variceal bleed happens within those first 6 weeks. If patients get through that period, their immediate risk drops significantly.
And looking further out, what are the main late complications we're trying to head off with our long-term plan?
The big ones later on are recurrent variceal bleeding, which, again, carries a high mortality risk each time it happens, and just ongoing decline in liver function, like worsening ascites or more frequent bouts of encephalopathy. Without effective secondary prophylaxis, the risk of that first rebleed is extremely high, often over 50% within a year or two.
We need to know who's most likely to rebleed or die. What are the strongest predictors of a poor outcome we can see at the bedside?
The severity of the underlying liver disease is paramount. High Child-Pugh scores and high MELD scores are the most powerful predictors of both short-term and long-term mortality. A patient in Child-Pugh Class C or someone whose MELD score is climbing rapidly is definitely in a high-risk category. Other really important predictors include failing to control that initial bleed easily and needing a large volume of blood transfusion, say more than 4 to 6 units of packed red cells within the first 24 hours. That suggests a very severe initial hemorrhage.
And you mentioned ACLF, acute on chronic liver failure. What does that diagnosis signal in terms of urgency?
Seeing ACLF develop, which is basically acute decompensation with organ failure superimposed on chronic liver disease, is a very ominous sign. Dramatically increases short-term mortality, often exceeding 50% at 28 days. It tells you the variceal bleed has pushed their already damaged liver over the edge. It usually requires very aggressive support and often triggers discussions about urgent liver transplant evaluation if the patient's otherwise a candidate.
Given that high risk of recurrence, secondary prophylaxis after the first bleed is absolutely critical for long-term survival. What's the standard first-line combination therapy to prevent esophageal varices from bleeding again?
For secondary prevention after an esophageal variceal bleed, the standard is combination therapy, a non-selective beta blocker, NSBB, plus repeated sessions of endoscopic variceal ligation, EVL. The idea is to tackle it from both sides. Use the drugs to lower the underlying portal pressure and use endoscopy to physically get rid of the existing varices.
Which NSBB is generally preferred now and why?
Carvedilol is often the preferred agent these days, usually aiming for a dose like 12.5 milligrams daily. This is especially true for patients with larger varices. Unlike older drugs like propranolol, carvedilol blocks both beta-1 and beta-2 receptors, but it also has alpha-1 blocking activity. This alpha blockade adds some vasodilation, particularly in the splanchnic bed, which seems to provide a bit more potent portal pressure reduction compared to traditional NSBBs alone.
And the EVL part isn't just a one-and-done procedure, it's a program.
Absolutely. It requires a commitment to a schedule. Repeat EVL sessions are needed, typically every 2 to 4 weeks. This continues until the endoscopist confirms complete eradication, meaning no visible varices are left. Then you shift to longer-term surveillance endoscopy. It's quite intensive for the patient.
Now, what if we do everything right? The patient takes their carvedilol, we complete the banding until eradication, but they still rebleed. What's the next step then?
If rebleeding occurs despite being on optimal medical therapy, the right dose of NSBB, and having had successful EVL eradication, that's generally considered treatment failure. This becomes a clear indication to move to second-line prophylaxis, which is TPS. At that point, TPS is needed to achieve a more profound and reliable reduction in portal pressure.
So the long-term plan isn't just about the varices themselves, but about managing the underlying engine driving them the liver disease.
Exactly. Long-term success depends on ongoing surveillance endoscopy, yes, but also aggressively managing the underlying liver condition. That means strict alcohol cessation if applicable, treating viral hepatitis, managing other complications like ascites effectively with diuretics and salt restriction, maintaining nutrition. It's holistic liver care.
Okay, let's quickly summarize that critical timeline for the acute bleed. What are the three things that absolutely must happen almost simultaneously right at the beginning?
Right. First, immediate hemodynamic stabilization, but remembering that cautious volume resuscitation, targeting that hemoglobin around 7 GDL. Second, start the drugs immediately, both the vasoactive agent, usually octreotide, and the mandatory prophylactic antibiotic, preferably ceftriaxone. Don't delay these. And third, arrange for urgent upper endoscopy, aiming for within 12 hours, but only after the patient is stabilized and the airway is safe. These three things need to launch together.
The sheer severity of acute variceal hemorrhage really demands this aggressive, protocol-driven approach with a key focus on spotting those highest-risk patients early on.
That early identification is critical. Recognizing that child PUB patient with active bleeding, score 7, or any child PUC patient right away should trigger the thought process for early tips. It allows us to potentially shift from just reacting to treatment failure to proactively intervening to improve survival in that sickest group.
Which brings us to a final provocative thought for you, the listener, to mull over. We know early tips significantly boost survival in these high-risk patients, but it comes at the cost of potentially much worse hepatic encephalopathy. So how should we practically and ethically use risk scores like Child-Pugh or MELD right at the moment of presentation? Should discussing early tips, including that difficult neurological trade-off, now be considered a mandatory part of our initial conversation and resuscitation plan for these high-risk patients even before the bleeding is fully under control?